So good afternoon, everyone. My name is Pamela Gardner, Lead Program Manager for the Delaware Health Sciences Alliance. Welcome to the 2021 DHSA Research Competition. I want to make sure that everyone is aware that today's event is being recorded and will be posted at a future time on the Delaware Health Sciences Alliance YouTube channel. For those not familiar with the research competition, this is an annual event and initiative for DHSA launching in 2019. Research teams are required to have collaboration across a minimum of 2 DHSA member institutions, and research must have a population health focus. For our 2021 event, an additional requirement for research includes a focus and/or impact on health disparities. We will hear from our 3 finalist research teams today. Each team will have 15 minutes to present their research and pitch to our panel of judges, as we like to say, our research sharks. I would ask that anyone who's not presenting to please mute themselves during the presentation. Teams will provide verbal pitches only. No visual aids or presentations are permitted. Our sharks will then have time to ask questions of the presenting team, and time permitting, we will also take questions from our virtual audience. Audience questions may be submitted through the Q&A function or chat function of Zoom. Our judges will score each team following their presentation. At the end of our event today, we will announce the winning team and awardees of our 2021 DHSA Research Competition and $50,000 grant. I'd like to acknowledge and thank my colleague, Dr. Kate Smith from the Delaware Academy of Medicine and Delaware Public Health Association for her collaboration and support of today's event. Thank you, Dr. Smith. I'd also like to thank our sharks for their time and expertise today. And before we meet our exceptional panel of sharks, I'd like to introduce my colleague, friend, mentor, and president and CEO for the Delaware Health Sciences Alliance, Dr. Omar Khan.
Pam, thank you so much. And I want to echo your comments here and thank our distinguished panel here for being with us. Dr. Smith, Kate, thank you so much for helping set up the background of all this. It's a great testament to the work across the partnerships of the Alliance that we do all these activities together as well. Pam is running the show here, and I want to thank Pam for her leadership for the last several years of Shark Tank in putting this panel together and putting together a terrific array of presentations. From my perspective, the research competition, which we affectionately call Shark Tank, really, is one of the best ways, I think, to do community engaged and relevant research. For one, it asks us to collaborate across institutions, which is already an issue in much of science, is that there's too many silos already. The second innovation here is that we actually go beyond even the Shark Tank model, for those of you who have seen that TV show, where a presenter presents to a group of panelists or experts, and then they make a decision, and then somebody is awarded the next step. In our case, the format is similar, where a presenter presents to our expert distinguished panel, but there's also room for community input. And that's something we've learned through our work across the clinical and translational research program, which we're all part of here through our work with the Delaware IMBRI program, which several of you are part of, which Dr. Stanhope heads up, and all of our research work, which essentially necessitates that you engage the community in the decisions that you make, which is why it's so important. Dr. David Wellen, for example, heads up the PEER program, which is a consortium among academic and community health systems for clinical research. And again, the same principles apply. We really should do in our Delaware Valley partners a lot of this work together and try to elevate the quality of work that we all do in that sense. So I really appreciate all of your expertise as panelists, as well as our audience who are joining us and who hopefully will ask some great questions. So thank you again, colleagues. And Pam, I will turn it back over to you.
Thank you, Dr. Khan. Now I'd like to take a moment to introduce our exceptional panel of judges. I will call your name, and I'm going in alphabetical order by institution, so somewhat random, but not really. If you could please give a brief introduction of yourself and your DHSA member affiliation. Dr. Rather.
You'll need to unmute.
I forgot the most important step. Sorry about that.
So my name is Asad Radha. I'm a colorectal surgeon here at Bay Health. Bay Health is, so to say, the new kid on the block when it comes to DHSA Alliance. We joined DHSA, I think it's been 2 years now. And also, as far as graduate medical education is concerned, we are just getting started. 3 programs, 2 more to come. I am the chair of graduate medical education here at Bay Health, and I'm excited to be here.
Thank you so much. We're thrilled to have you join us today. Dr. Lee?
Good afternoon. My name is Dr. Marsha Lee. I am a family medicine physician at Christiana Care. I am also the director of the Harrington Community Partnership Fund, which lives within the Institute for Research on Equity and Community Health. I also serve as a clinical faculty within the family medicine residency at Christiana Care. I'm excited to be a shark today. Thank you for having me.
Thank you so much for lending your time and expertise. Dr. Swanson?
You're muted.
Thanks. John Swanson here. I'm the retiring chief of kidney transplant at Christiana Care. Started the program here 15 years ago, and it's time to hand it on to younger hands. But I'm also the Delaware Academy of Medicine president, and great pleasure to be here today to help further research in our area.
Dr. Swanson, thank you for your time. Dr. Fananich?
Good afternoon. It's wonderful to see you all. I'm Vicki Fananich. I'm Executive Director of Research for Nemours Children's Health System in Delaware and Florida, and a molecular geneticist by background and training.
Thank you for joining us today. Dr. Weinstein, George Weinstein, my apologies.
Greetings, everyone. My name is Mindy George Weinstein. I'm the Chief Research and Science Officer at the Philadelphia College of Osteopathic Medicine, overseeing research programs for our 3 campuses. I'm also a professor in the Department of Biomedical Sciences and maintain my own active research program.
Thank you so much for joining us. Dr. Wellen?
Yes, welcome everyone. I'm excited to hear all the presentations. I'm Dave Whalen. I'm the Senior Associate Provost for Clinical Research at Thomas Jefferson University and the Chief Operating Officer for the peer consortium that was just mentioned by Omar. Thank you.
Thank you for joining us today. And last but not least of our panel of judges, Dr. Stanhope.
Good afternoon. I'm Stephen Stanhope, Associate Vice President for Research at the University of Delaware. I'm also the principal investigator of the Delaware IMBRI program. And I'd like to take this moment to congratulate Omar Khan and Delaware Health Science Alliance. These are 3 outstanding proposals. I mean, they really link together some strengths across the Delaware Health Science Alliance network and such. And really exciting to see this whole Shark Tank process really grow and mature over the years. So I'm really excited to hear the presentations.
Thank you so much for joining us today. All right, so before we hear from our first team for the 2021 Research Shark Tank competition, we have with us today our 2020 awardees who are here to provide a brief update on their research and the impact the Delaware Health Sciences Alliance grant has had on their work to date. Joining us in representation of the 2020 awarded team, representing a collaboration among DHSA members Christiana Care and Nemours Children's Health, are Doctors Vanessa Downing and Stacy Boyer. Dr. Smith should be elevating you now.
Hi, Vanessa. Hi, Stacy.
Hi there. I see Stacy gearing up.
Sorry, that was just a very strange shift to be elevated to a panelist. Hi, I'm Stacy Boyer. Nice to see everyone.
Yes, thanks so much for having us back. And Stacy is going to share her screen, and then we'll be able to proceed through our slides. So I just want to start by introducing myself. My name is Vanessa Downing. I'm a psychologist by training, and my specialization is in physician and healthcare worker well-being. And we were simply thrilled and honored to be the recipients of the DHSA award last year, and really thrilled to be able to come back today to represent our research team and to report on what we've been doing in this last year. So we'll go through this, hopefully a quick little thumbnail overview for you of what we've done, and we'll hold for any questions at the end. So first of all, just wanting to acknowledge that Stacy and I are, of course, part of this larger team that includes Dr. Maureen Leffler from Nemours, Dr. Sam Van Horn, who is now at the University of Delaware, and Dr. Megan Call, who is a colleague from Utah, University of Utah. So just wanted to give you a little bit of a background, because I know for the most part, this is a different group of sharks than we met with last year. So the premise of our research proposal was that healthcare worker well-being is its own emerging specialty within the fields of psychology, social work, and mental health. And that as we saw across the country, increasingly large healthcare systems were creating roles specifically for healthcare worker well-being specialists, where they were no longer kind of doing this on the side, but really having dedicated time to help take care of healthcare workers on the job in the workplace. So we saw that as an opportunity to potentially mine for whether any best practices were starting to emerge in this field of work, certainly a nascent field in psychology. So one of our basic premises was that medical culture, Stacy, just go back one, was that medical culture is a distinct, specific area of cultural competence. And that in the same way that we would expect psychologists and other mental health professionals to really be aware of their cultural competence with different populations and grow and develop their cultural competence, that those who choose to work with physicians and other healthcare workers would also be expected to be able to develop and demonstrate their competence in working with this population. But what we noticed was that there was no real culture-specific training available to psychologists and other mental health professionals who might want to specialize in working with this group. We knew that this was something that was urgent, more urgent than it's been in a generation as the pandemic unfolded. So the goals of our study were to do mixed methods assessment of healthcare worker well-being and mental health needs, a mixed mental health assessment of healthcare worker well-being specialist psychologists nationwide. So really looking deeper into the lives and the work of the people who were psychologists embedded in healthcare systems solely with the role of serving their healthcare worker colleagues, and the creation of an evidence-based educational session for mental health providers, really focusing initially in Delaware, but eventually going nationally and internationally as appropriate.
I have no idea.
Yeah, so Vanessa, there's weird feedback. All we can hear you is you saying on over and over again. So maybe Stacy wants to take over.
Sure. So we launched this mixed methods study, and as Vanessa mentioned, we met with healthcare workers and also with well-being specialists nationwide, and we created this educational module that is in the works. We'll talk about kind of where it's at right now in terms of distribution nationwide, and then we plan to do an RCT of the CE module to demonstrate effectiveness. However, this is shifted to a smaller field study as we feel it's more imperative to get it out and make mass distribution possible. So we wanted to share just a few quotes to give you a snapshot of what our results look like. So our healthcare workers really spoke to the tremendous need and for services and pressure that they've been under. And here's a quote that someone offered: "It's really hard to be that person, that only person there for a patient while they're dying." And I think a lot of times we just normalize and associate everything within our own selves. Like, I could be in with a patient and I'm like, well, this could be my mom or my dad, this could be my family, and it really feels terrible. Or I say to my staff, what are you going to do for yourself on your time off? What are you going to do for you to take care of you? And I can't tell you how many times I get, I'm going to go home and drink a bottle of wine, and then I'm going to go to bed. So one of the things that we're seeing on a national level, unfortunately, is that healthcare workers, given the incredible demands of folks over the past nearly 2 years, we're seeing higher rates of substance use. And then thinking about the busyness, the meetings during lunch, meetings after work, charting all night, weekends, trying to get everything done, it's extremely difficult. And then thinking about personal implications and feeling, one person described, I'm sinking, but a little slower than the world, so I'm okay. And I think probably everyone in this meeting is aware of the burden that healthcare workers in particular have faced this past year. So we had some themes emerge from our interviews with them, and then from our well-being specialists who really said very clearly, you're going to lose physicians if you don't understand what they're up against, that there's a real desire to be in the healthcare system and in that clinical role, but also an awareness that that same system that's so valuable to you may actively be hurting you when you're a clinician. Physicians never have any downtime. They're never fully unplugged. And if they do fully unplug, that means that they're going to have to ask a friend and a colleague to plug in even more to cover them. It never ends. And thinking about the experience of a healthcare worker during a disaster is profoundly different than everyone else's. And that they need to know, if they tell me, being a psychologist, the ways in which they're suffering, that I'm still going to know that they are a good doctor. So what our well-being psychologists were really saying is that that being a clinician is a part of the identity, and we need to be very thoughtful and sensitive to that in our treatments. So here's a brief timeline of our research study. We received the very generous gift from DHSA, which I will tell all of you who are applying, they've just been absolutely wonderful to work with and very accessible, and really champions for this research that we think is going to be tremendously impactful. In December of 2020, we got our IRB approval and we began quantitative data collection. And then in January, we began the qualitative data collection of healthcare workers and well-being specialists across the country. We had our first wave of data analysis shortly thereafter, and then we began qualitative data analysis following that. We did produce the 2-hour CE module, and I'm excited to share that we got accreditation from the American Psychological Association for all mental health providers who are viewing the program to earn 2 CEs for their participation. So we'll talk about kind of where we are now in December, but just a couple notes about the emerging themes from the qualitative data that speaks to our educational module. So confirming our hypothesis, the medical culture is distinct with far-reaching and wide-reaching impacts on individual identities. It shapes how folks cope in the face of adversity. It promotes certain coping styles, expectations, and wishes in the therapeutic relationship. And that unfortunately, the training experiences and work environments that healthcare workers are in are not well understood by the private practice mental health professionals who are typically engaged to provide treatment to them. And that there are also very few specialists in providing mental health care to healthcare workers out there in the community. So our CE hopefully will bolster people's understanding and really help them to develop some competency to treat this population. We found very specific key behaviors that can facilitate or provide or become barriers to effective working relationships between healthcare workers and mental health professionals for treatment. And I'll show you our little model about that in a minute. We have very specific logistics recommendations for folks. We teach people about the medical culture so that they can begin to develop cultural competency and thereby foster the therapeutic relationship. In psychotherapy, we understand that the #1 curative factor is the therapeutic relationship. And for that to be established and maintained and to deepen, we know that that cultural competence piece needs to be there. And then finally, we found things that facilitate or serve as barriers to that alliance that I'll show you in a moment. This is a snapshot of one slide of our study where we describe in the continuing education module that people will view, where we describe the study itself. But one of the interesting things that I'm excited about for our module is that it's very interactive. So here is a slide that talks about the driver dimensions that can either lead clinicians towards burnout or towards feeling engaged and joyful in their work. And we have exercises throughout the module that participants will complete where they can engage with this, where they can run a day in the life scenario to understand what it's like to be a physician or a hospitalist during these times, and where they can really apply the things that they are learning so they have practice to deepen their education. Here is the practice model that we came up to develop a clinician-friendly practice, and learners can click on each aspect of this model and learn specific questions that they can ask healthcare workers that they are seeing for treatment, and learn about cultural competency in terms of the culture of medicine and how they can incorporate that into their practice, as well as how to deepen the therapeutic alliance. So where we're at now is that we are running our field study that looks at the effectiveness of the continuing education module in terms of people learning what we hope that they will learn. And we're using 2 large behavioral health practices in the state of Delaware for that. We are finalizing our qualitative coding. We've identified 4 different publications that we're hoping will come from this research. And so we're hoping to we are currently shaping those publications and beginning to write them up. And then as soon as we're done with our field study in about 2 weeks, we anticipate mass distribution of the CE module. It is free. So everyone who's a mental health provider across the country who wants to participate and wants to take this module can do it for free and earn continuing education credits for free, thanks to this grant that we've received from DHSA. And it's been so well received that Blue Cross Blue Shield and Aetna want this for their entire panel of mental health providers, as well as folks like Vital Work Life who, or Tend Health, who really serve physicians in particular. So we're hopeful that this is going to have a great impact and improve the experience of healthcare workers in treatment for years to come. That's all that we have, but we'd be happy to answer any questions if anyone has any questions or thoughts.
Stacey and Vanessa, thank you so very much. This is Omar here. I just wanted to add my appreciation for the wonderful work that you've done in very challenging circumstances, including not just supporting folks individually who are working on the front lines, but actually creating this evidence base that is going to be an enduring material and hopefully, as you mentioned, through your efforts, be propagated, be used elsewhere, and hopefully continue to evolve. So very much appreciate all your commitment to this work. Thank you.
Thank you all for your support. It's been tremendous. Thanks.
I would just like to echo Dr. Khan's comments and thank you both for taking time to join us today to provide this update. Prior to the pandemic, certainly well-being and wellness for providers was emerging concern and emerging area of focus, and throughout the pandemic has certainly become more important. And so thank you for all of the work that you're doing in support of those who are providing care for our communities. As some of our Sharks were with us last year when you originally pitched and presented and were awarded, and some are joining us and hearing this presentation for the first time. I would like to offer a few minutes to our Sharks should they have any questions or comments on your work before I know that you both have other commitments that you need to attend.
This is Vicki. I was a Shark last year from Nemours, and this is tremendous work. I'm just so incredibly proud, and I had a question about whether you're going to publish it and stuff, and I understand there are 4 possible manuscripts that will come out of this, but I'm wondering too if there's an opportunity to educate individuals outside of the healthcare realm, because this resonated with me. And even though I work for a healthcare system, I'm a PhD, I'm a researcher. And we always talk at Nemours about those that care for patients and those of us that care for those who care for patients. And I would think this would be very, it would just be wonderful information for a lot of us to hear and understand what our healthcare providers are facing. We have somewhat of an idea, but hearing it from you and collecting this information and finding a way to disseminate that to others so that they understand what healthcare providers are facing, I just think it would be a terrific opportunity, and I wondered what your thoughts are on that.
So with regards to mental health professionals, that will absolutely be the case, and we feel that that's very important, because one of the common things that people would report is that they would go to see a mental health provider in the community who's not associated with the health system, and that well-intentioned provider would say to the physician, you know, I really think you ought to leave the field of medicine. And that physician would immediately say, I have worked so hard. This is part of who I am. I value being able to provide care. I'm just understandably struggling right now with the demands, right? And so we want to teach mental health providers, no, you don't say that. This is a better question to ask, and this is how we can respond more appropriately. And so it is planned to go to mainly community providers. However, I do think that there's an interesting opportunity here, and I'm hoping through publications to educate consumers beyond mental health about some of the things that folks are facing. Certainly, we've seen a lot in the media, but we're thinking with we're hoping to publish 4 different publications in different types of journals, so that it reaches a wider audience. And some of the publications will focus on the mental health treatment, while others might focus on the need for well-being specialists and how you build that position and what that looks like, and how we can begin to think about clinician well-being. So I'm hoping that that'll have a wider distribution, and we are certainly open to exploring other thoughts. I might reach out to you, Vicki, if that's okay.
Please do. And my last name is Fananich, just in case, you know, I didn't say that, but I would love that. And I guess what it really, and I'm sure the others on this panel feel the same, what just is incredible is not only the impact you've had with this relatively small award, but the cascading effect and the impact that you're going to have, really, I could see for generations to come. I mean, this is nationally, it's being nationally adopted through the health insurance systems and as you said, dissemination through publication. So just phenomenal.
Hi, it's Stephen Stanhope. If I could just jump in. I was not a shark last year, and so therefore it turned out so great, I think. But I'd like to just point out the concept that if there's any way for you to explore and to link to any of the NIH IDEA award mechanisms, and I was thinking particularly the CTR, kind of community-based, it's clinician-based and such, might give you a pathway for some sustainability and going down some different venues. And the other thing that just popped to mind is you might consider potential commercialization routes at some point in time, which is truly an ideal way to sustain activities as well. And NIH right now is funding small business incentive grants to IDEA states, which Delaware is one of them. And so with collaborators in Delaware and such, you could potentially leverage SBIR's TTR funds, phase 1, phase 2 and such, and work towards commercialization. And that could also really help in terms of kind of sustainment of the effort and have it continue to grow. Just some thoughts. Great job.
Thank you.
So George Weinstein, we will have you be our last question and comment for our 2020 awardees.
So yes, so first I want to congratulate you on the tremendous progress that you've made. It's really quite remarkable considering the obstacles. But I also see this as a great opportunity because now you'll be well positioned to do a comparative study of your first cohort of subjects that went through the first severe wave of the pandemic with a potentially, second wave, and it's not clear to anybody what that's going to look like yet, but certainly the stress of the knowledge that the Omicron variant is spreading might create your initial population plus the added effect of the sustained having to sustain your adaptability to these incredibly stressful pandemics.
Absolutely. Thank you.
I going to ask Pam if you could afterward share our contact information with the awardees, just in case they don't readily have our information available.
Absolutely. I would be more than happy to.
Thank you.
Thank you for that. And thank you everyone. And Drs. Downing and Boyer, thank you again for your and your team's incredible work, impactful work, and for joining us today for that update. It is now time to officially kick off our 2021 competition. My colleague, Dr. Kate Smith, will be elevating our first team to present. I'd like to remind our presenting teams that our agenda is tight today, and we will be strict in adhering to the 15-minute allotment for pitches. Team 1 represents a collaboration between Thomas Jefferson University and Nemours Children's Health with a focus on access to healthcare for children with autism. Dr. Smith will advise when your time begins.
All right, I think I got everybody up. Have a look around and see if I missed anyone. All right, unmute yourselves and your time begins now.
Hello, my name is Danielle Lynn, and I will be presenting today with Rachel Boyer. We are third-year occupational therapy doctoral candidates completing our candidacy at the Jefferson Autism Center of Excellence. We will be presenting on behalf of our group today, and thank you so much for having us. So everyone here, we would like you to please close your eyes. Now imagine yourself going to the doctor's office. There are people in the waiting room, and their voices are echoing around you. You are trying to focus on what the receptionist is saying, but the sounds are getting louder and louder. Someone is tapping their pen on their clipboard, and it sounds like the banging of a drum. There's no quiet place for you to go. There is no escape. The lights above are buzzing incessantly, and you are taken down a hallway, and doors are opening and shutting, but it sounds like slamming. You can hear it through the walls of your exam room. You find yourself trying to cover your ears because the sounds are too loud. You start humming and rocking back and forth to comfort yourself. Someone unexpectedly touches your arm and the pressure is too much. You have to get out, you have to leave. Open your eyes. That was a snippet of what an autistic child or persons may experience when trying to complete a routine medical exam. It seems overwhelming and scary, right? It doesn't need to be that way, and we're here to help make it better. We're here today to propose a project to train medical staff on sensory needs and strategies to support those needs, as well as to implement these sensory strategies in practice with autistic children and youth during routine medical care.
So why is this important for us to do? Well, according to the CDC, it's estimated that 1 in 54 children are diagnosed with autism spectrum disorder. In the state of Delaware, about 4% of individuals have a diagnosis of autism spectrum disorder, which equates to approximately 30,000 individuals. Autistic children have an increased need for routine medical care, as medical comorbidities are more common in autistic children than in the general population. Autistic children are 1.6 times more likely to have skin conditions, 1.8 times more likely to have food allergies, 2.1 times more likely to have ear infections, and 2.2 times more likely to have severe headaches. You're hearing all of these numbers, and we know it's a lot to take in. The main takeaway from these statistics is that many children are being diagnosed with autism, and there are a lot of medical needs requiring medical care for autistic children.
When thinking of places pioneering medical care for autistic children in Delaware, the Swank Autism Center may come to mind. The Swank Autism Center provides outpatient care to autistic individuals, including evaluation, diagnosis, and support services. The Swank Autism Center serves over 2,000 autistic children and youth between the ages of 3 to 10 years through team-based care. The team includes experts in child psychology, psychiatry, and developmental pediatrics. So it makes these medical visits challenging for autistic children and youth. Well, like you experienced just a few moments ago, there can be a lot of overwhelming sensory input from the surrounding environment.
Neurodiverse individuals often have difficulty taking in and responding to sensory information from their environments. Some individuals need increased sensory input, while others react poorly to sensory stimuli around them. Common sensory response patterns include hyperresponsiveness, hyporesponsiveness, and sensory interests and repetitive behaviors. Children with sensory needs may often demonstrate challenging behaviors in a variety of ways depending on what type of sensory information they have difficulty with. Sensory interests and repetitive behaviors can include self-stimulatory behaviors such as rocking, twirling, or hand flapping that provide comforting sensory input to the child. Difficulty with sensory input is a well-recognized feature in autism, with reports indicating the presence of some form of sensory processing difficulty in up to 95% of autistic children.
As you pictured with us earlier, medical centers can have a number of challenging sensory experiences. The purpose of this project is to improve access to and success during healthcare visits for autistic children at the Nemours Swink Autism Center by addressing these sensory challenges. The specific aims are to design, implement, and evaluate an educational program for health and developmental providers at Swink to enhance their understanding of the sensory challenges in autism and increase strategies for managing these during healthcare visits. Our other aim is to design, implement, and evaluate individualized sensory experiences for autistic children and their families for use during and after their healthcare visits at Swink. So what does this mean? We want to train staff on sensory strategies and then implement these strategies with autistic children seeking medical care.
Research shows that the use of sensory adapted equipment and environments can increase participation during healthcare visits and reduce psychological stress and maladaptive behaviors associated with visiting a healthcare provider. Research has shown how sensory adaptive environments in emergency rooms and dental care offices have yielded positive results in decreasing anxiety and allowing for full treatments to occur. Our work with ophthalmologists to create sensory-friendly vision clinics has yielded very high client satisfaction and greater completed exams, allowing autistic children to receive proper eye diagnoses and treatments. To address a child's sensory needs and reduce anxiety and challenging behaviors, specific sensory-based strategies are used. Some frequently utilized items include noise-canceling headphones, sunglasses to reduce light stimuli, weighted blankets or wraps, and handheld items such as stress balls, a variety of textured objects, reusable popping bubbles, and more. However, these interventions are often not implemented within the context of routine medical care.
This current research project aims to contribute to a growing body of research by examining the effects of environmental modifications and sensory-based strategies with autistic children within the healthcare environment. As this is currently not standard practice at the Swink Autism Center, this project will be implemented in 2 steps. The first being an asynchronous training for staff members at the Swink Autism Center. The training component will include an overview of, firstly, a common sensory response pattern for autistic children. Second, an introduction for sensory tools, activities, and environmental modifications to enhance healthcare delivery for autistic children. And lastly, a guide for choosing appropriate sensory adapted experiences for their autistic patients based on each child's unique sensory profile. Trainings will utilize evidence-informed adult learning strategies to assure a comprehensive and detailed understanding of content. All Swink Autism Center medical and involved staff will have access to these trainings.
The second aspect of this project is the implementation of individualized sensory toolkits. In order for us to better understand each child's sensory needs, we will remotely conduct a sensory questionnaire to determine specific sensory likes, dislikes, and sensory-seeking behaviors using a standardized sensory assessment. This information will be used to develop individualized sensory toolkits available upon arrival in the Swink waiting room, designed to target the specific sensory needs of each child so that they can feel at ease during the visit. The sensory strategies used are based on evidence in the literature showing that autistic children are responsive to multisensory environments and sensory supports to address each autistic child's sensory needs. Unlike a stationary sensory room, which confines sensory supports to a single location away from medical exam rooms, these sensory toolkits are easily portable and can be utilized in virtually every context of the healthcare visit, from the waiting area to the exam room at the Swink Autism Center.
Though current research supports the individualization of sensory adaptive environments and individualized sensory-based adaptations, they are tools that are rarely used in healthcare. The Jefferson Autism Center of Excellence has begun to implement these strategies at the Wills Eye Center by providing successful sensory-friendly vision clinics that provide sensory strategies with decreased wait times, handheld items, and a slower pace of visit. Patient outcomes have been measured using an adapted client satisfaction questionnaire, and caregivers have consistently reported high satisfaction with these sensory-friendly vision clinics.
While this proposed project is beginning through a research endeavor, the end goal is that every child who receives services at the Swank Autism Center will eventually have access to individualized sensory toolkits. The sustainability of this project relies on multiple facets, the first being the implementation and access to staff trainings. This allows staff members continuous access to autism and sensory information, as well as trainings for new staff members to become familiarized with. The second facet of sustainability is the equipment itself. All of the sensory equipment purchased will remain on site at the Swank Center, and all items will be chosen on the basis that they can be cleaned and reused. And the final portion of sustainability is embedding these procedures into routine care. After this pilot study, the Swank Center can incorporate the surveys and outcome measures into their patient email system to be a part of the routine care that families and autistic children and youth receive at Swank.
When designing this project, it united and brought Jefferson and Nemours goals together to address health disparities in a bold and innovative way. Thomas Jefferson University's motto of improving lives is interwoven into this project, as we find a huge disparity within healthcare in terms of behavioral health. Little attention has been paid to addressing sensory systems within the healthcare system. Through boldly moving beyond, as Nemours' motto states, we endeavor to move this project into the lives of autistic youth and change the current standards of healthcare delivery for them.
Not only does this project have a union of priorities and advocate for population health, but it also brings together leaders in the field of autism. Dr. Schaaf and Dr. Treadwell-Deering, as well as a team of occupational therapists and medical staff, are dedicated to providing the best quality of care for autistic children and youth. Dr. Schaaf is a highly renowned neuroscientist and occupational therapist who has devoted her career to the study of sensory features in autistic children and other neurodevelopmental conditions. She's also the director of the Jefferson Autism Center of Excellence. Dr. Treadwell-Deering is a board-certified child and adolescent psychiatrist, and she's also the director of the Swank Autism Center at Nemours, who can help provide world-renowned medical care. All team members are currently practicing clinicians, which eliminates the research to practice gap that can often occur.
We anticipate a multitude of outcomes to arise from this study. To measure the effectiveness of staff trainings, we'll administer an adapted questionnaire to assess knowledge and competence for working with autistic children and youth. We anticipate that scores for both knowledge of autism and sensory systems, as well as perceived confidence for working with autistic patients, will increase. We will also implement a Likert-style survey to assess the perspectives of autistic patients and their families. We anticipate that families will report high levels of satisfaction with their visits, and that the individualized sensory toolkits and adaptations to the environments will be noted as supports for the visit. With these supports in place, we hope that the children are able to more successfully participate in all aspects of the healthcare visit, leading to greater long-term health and well-being.
Now close your eyes again. You're entering the building for your medical exam. The receptionist has a pair of noise-canceling headphones ready for you that you put on while in the waiting room. No overhead buzzing, no tapping of pencils. You feel calm right now. You feel like you're in control. The staff come to bring you back, and they talk with you before engaging in touch. When you get to the exam room, staff offer you a weighted wrap that you choose to put around your shoulders, as you often need deep pressure to calm yourself. You like pulling the wrap around yourself. You feel warm and enveloped in a state of comfort. You complete the exam this time. Open your eyes. That visit felt different, didn't it? Think about what a difference these sensory supports can make in the lives and experiences of autistic individuals. Routine medical care needs to change, and we're calling on you today to join us as change makers. Let's make a difference in people's lives together. Thank you.
Thank you, Team One. I think you had minutes, maybe seconds to spare, but well done. Thank you so much. And thank you for presenting today on your incredible work on enhancing positive healthcare experiences and delivery of care for children with autism here in served in Delaware. I'd like to now open it up to our panel of judges and sharks for their questions and comments.
Pam, do you mind if I lead it off?
Go right ahead, Dr. Stanhope. Thank you so much.
Hey, listen, I was really excited to hear your presentation and to read the proposal and all. And I had all these notes on it that I wrote down. And one of them was, are they really aware of all the sources of sensory input to individuals? I can check that box and things like that. Are they using a generalized model? Do they really understand how these things interact? And are they going to apply it in kind of a personalized way? And I literally listened to your presentation. I just started checking the boxes. And the only aspect that I didn't check was the concept of, it seems as if you're still using the standard medical model that the family and the child would show up to the hospital and such, and then they would receive perhaps the sensory devices from the toolkit that are optimal for that particular child. Would a more generalized approach be that it's provided to the family and that at the time of leaving the house, the child's able to implement those devices and such and be able to actually use in the community to really actually help the child and the family in a broader way? And if that's the case, why not choose that option versus the standard medical model that they'd receive it at the receptionist's office after some of the triggers have already been fired off?
Yeah, so that's a great question. So part of this project as well is to implement some pre-visit adaptation. So we will also be sending home what we call social stories. So that kind of prepares the child on what they will see when they get to the hospital. So it gives them a whole story of when you get to the parking lot, you're going to park in this lot, and then you're going to walk through this hallway, and there you will run into the security guard, and he will greet you. And specifically with COVID, it also has, you will use hand sanitizer to wash your hands. It'll feel kind of gooey and you might not like that. And these all are accompanied with pictures. So we kind of start prepping at home first to prepare for this visit. So we also are trying to implement different tools such as preparing social stories for different medical visits. For example, when we met specifically and talked about the different ideas for this project, we learned about a meeting that a parent came and talked about their child going for an EEG and how she asked about, maybe getting some of the supplies beforehand so she could educate her child on what it would be like. And so we kind of talked about creating different social stories for all those different medical situations so the child could be prepared beforehand. And know, I'm going to place a lead here, or I'm going to place, something on your shoulder for any different type of medical procedure. So they would have that awareness of what would be happening beforehand. So we could send home different social stories for different types of medical visits.
And I'd like to jump in. I'm Rachel Dumont. I'm also part of the Jefferson Autism Center of Excellence. Part of the the sensory surveys, as well as the standardized assessments. Part of the sensory survey also includes really getting to see what the parent is utilizing at home with their child, so what is successful, and also getting to identify what items that the parent themselves would also be bringing in too. So there's also that aspect of families do have some portable items that they have for their child that they like to bring as supports, but sometimes things aren't portable. So being able to have them on site to help facilitate that upon arrival. So it's really this opportunity to have these collaborations and to really best support a family and a child according to where they're at.
And finally, if I could add really quick, I think that there's a misconception that autistic children are either sensory seeking or sensitive to sensation. And I've heard from a speaker that instead of generalizing like that, a more accurate analogy would be turning the dials on like a DJ board. So you might need to increase this and decrease this. You can't just generally say that somebody is sensitive or that they're a seeker. And so it's important, and what this project will be focusing on is providing the supports that are needed and applicable to the specific environment at SWANC. So the supports that a child might need at the SWANC Autism Center might be different than the supports that they would need if they were to go to a grocery store or to a movie theater.
I have some experience with this, 32 years of my son with autism, but, and my daughter is a special needs teacher. I know that we have many years of, through the educational system of an IEP and other multiple behavioral observations, would it be beneficial to coordinate with the schools to, I mean, you'd probably get a lot of your data from them as well, because they would have on a day-to-day basis. My son was in school from age 3 to 21 and plenty of data. And I'm just wondering if there would be an opportunity for coordination with people who've been, you know, really caring for this child for years. Just throw it out there as a possibility. And then the other thought is to, just Dr. Stanhope's point, would there be, you know, some maybe offer to, you know, purchase the equipment on their own? And so that you would be able to facilitate, some people would have the means or whatever, or some way to gain funding, but the idea that to have that available, I suspect it would translate to many, many situations. Anyway.
Yeah, thank you. I think definitely sensory systems are something that is not very well understood in all aspects. So definitely having the resources from the school is important because they do understand and they spend a lot of time with these children. So I think that's a really important aspect. And also, we do have a very unique perspective in knowing about these sensory systems and knowing what tools can benefit each child if they have, you know, a unique sensitivity to light or they're really into tactile information. And I think it's we have a unique perspective that we know what tools and toys they might really be interested in. So I think that is definitely a unique perspective that we could supply parents with information on what tools they could purchase for their own home toolkit, I would say, and what kind of sensory information they could have at home. Because what we could have for a hospital toolkit might not be the same things that they could have at home. Like we could have, so part of the stuff we need for the hospital needs to be easily cleaned, you know, especially with COVID-19 now, easily cleaned and safe to keep in the hospital. So providing lists and resources so they can have their own sensory strategies at home is definitely an important aspect as well.
Can I ask a question? Dr. Rather, thank you. This is fantastic. And I feel you're onto something. This is something which can be expanded to other clinical settings. In my world, you know, autistic children that have to have elective surgery, I think that's something down the road, you know, you should consider. And surgery can be challenging for a lot of patients, not to speak about autistic kids. So the question I have is, do you have any specific inclusion-exclusion criteria, or do you want to, or every patient, like how do you enroll patients for this study?
Currently, our inclusion criteria is a diagnosis of autism and to be a patient at the Swank Autism Center, because that is where we will be conducting our study. So that is our current inclusion criteria for this study. And we hope to expand this to be just standard practice of care after this initial study is concluded. So we hope after that's done, we can hopefully expand this project further. As we stated before, we've done some sensory friendly vision clinics at Wills Eye, and since then we've reached out to other universities and ophthalmologists kind of around the country, and we've started to expand that and do trainings at other places. So we hope maybe we can do that as well with this project.
I'll just say a little something to that too about that in terms of inclusion criteria. Also, for many of our studies, we do a sensory assessment prior to make sure that the child is having sensory issues, challenges, or can benefit from sensory interventions. And that's just a really important theme in this work, is individualization of what we do with them and appropriate characterization prior to choosing anything or any strategies or tools that we'll be using. So also looking at, as Danielle and Rachel said, their sensory profile prior and assuring that they do have these sensory issues.
Thank you. Excellent presentation. Definitely see how this could be very beneficial for many of our patients. My question is regarding, do you anticipate any barriers for the patients completing the satisfaction surveys post-visit? I know that many patients may be nonverbal, and what is your process or thinking to collect that information?
Yes, so part of the process is kind of seeing how we can make the satisfaction questionnaire fit for the patient. So when we've done this previously with our vision clinics, we've used a lot of pictures so that the patient can point to say if they were satisfied, like, did you like this part of the visit? Yes or no? Did you feel overwhelmed? And using kind of our verbal, being able to explain it ourselves, and then having them use what skills they have, if they have an iPad to explain or anything like that, using their verbal cues.
Yeah, I can talk a bit more to that. In terms of the child surveys, we've used, when implementing the sensory-friendly vision clinics, we've used images of different kind of smiley faces, so the child can point to indicate how they felt about different aspects of the exam and how they felt about different supports that were available to them. And that's also why it's important that we're gaining the perspectives of the parents and caregivers as well. As part of the parent and caregiver satisfaction survey, we do ask how they felt that their child was feeling during the exam. And while the parents and caregivers, you know, they can do their best to indicate to us how the child was feeling. And obviously we want to get the child's perspective whenever possible. But if for some reason that's not possible, we are getting at least the parent and caregiver feedback.
Thank you all. We are at time. I do want to ensure that our panelists and judges are aware of the two comments from Drs. Wellings and Schaaf. The Swank Autism Center works fluidly with school districts to advocate that children are receiving adequate supports during the school day. We would certainly be able to assist in pursuing the idea to provide sensory advocacy and school supports, such as IEPs, and that the idea of including the school perspective is a good one and will include. So at this time, I'd like to bring our group one to a conclusion and invite our sharks to go ahead and proceed to the scoring and the rubrics with the electronic links that were provided earlier. Judges, we will be available and we'll ask group one to kind of hang on. I know that we're heading into a break, but maybe hang on as the judges are completing the rubric, should there be any final additional questions or points for clarifications as they're scoring you. I'd like to make sure that you remain available. We will reconvene for everyone else at 2:10. Thank you all. As Dr. Kate is elevating our second team to present, again, we'll be strict in adhering to that 15-minute allotment for pitches. Team 2 represents a collaboration between Thomas Jefferson University and the University of Delaware with a focus on promoting nutrition through music. I believe the members are all elevated at this point, and Dr. Smith will advise when your time begins. Best wishes.
All right, team 2, take a look, make sure everybody's elevated. And if so,
I just don't see Matthew's face. I don't know if he, oh, there you go. Okay, sorry, just checking.
All right, your time starts now.
Hi, everybody, and I love that you start off with music there, Omar. So good afternoon, Sharks. I'm Dr. Allison Carpin.
And I'm Dr. Katie DeSantis.
I'm Matthew Williams.
And together we're a collaborative team from the University of Delaware, Conscious Connections, Inc., which is based in Wilmington, and Thomas Jefferson University. And together we're seeking $49,912 for our research project, which is going to promote nutrition through music. Katie?
Thanks. Our project aims to address nutritional health in an effort to address the persistent childhood obesity epidemic. In Delaware, more than 30% of public school children are overweight or obese, and the condition has gotten considerably worse during the pandemic. This puts Delaware at the 16th highest childhood obesity rate among states in the US. This is of concern because only 2 out of 10 children who enter adulthood as obese will return to a healthy weight. And we know that weight status is an important predictor for our most prevalent chronic diseases, including heart disease, diabetes, and some cancers. And it can complicate the treatment of infectious diseases like COVID-19. A recent survey of Delaware residents found that 13% have been diagnosed with diabetes, a figure that has really dramatically increased since 1991 when it was only 4%. And these and related conditions have placed our current generation of children for the first time at risk of living a shorter lifespan than their parents. While seeming like a paradox, the same communities that experience high rates of obesity also experience food insecurity, which is the inability to access and afford enough quality food. In a recent assessment of food security among Delaware residents, the 19802 zip code was identified as being in the top quartile for food insecurity ratios, and its residents represented 30% of respondents who reported being food insecure, along with neighboring 19801 residents. This neighborhood has predominantly Black residents and has experienced structural inequalities, with violent crime nearly double the national rate and poverty rates nearly double that of surrounding areas. In Delaware, we not only struggle with obesity, but also with disparities in obesity rates, which leave Black and brown children and children from low-income families at highest risk. Science recognizes that the root causes for disparities in health include unjust access to quality health care, as well as numerous social and economic inequalities. Food, education, and community well-being are all important factors that explain disparities. Indeed, diet-related disease does not impact all communities equally, and extensive research has shown that where you live has direct impact on how you access healthy food, your diet, and overall health. The Delaware Health Sciences Alliance priorities have recognized the importance of improving equity across the state, and our research is closely aligned with those goals. Allison?
So music. We know that music is an important mirror for life. And in it, we reflect our feelings, and we also have our feelings reflected. And the words and the sounds can shift our mood and can influence our attitudes and beliefs. However, more traditional forms of education rarely use music as a conduit, and many communities where educational opportunity has been compromised historically and as a result of COVID has realized that there's an urgent need to get children re-engaged. Our research represents an innovative approach to nutrition education, and it's also feasible and builds on other work that Matt is going to share here in a minute. Let's dive into what we know about music for just a second. We know that music and the arts do open minds and allow children the chance to think about who they are and who they want to be in a much larger context. This is really a very compelling art form, especially for adolescents. And if everyone on the call today could think about the songs that we had in our adolescence, I suspect that many of us can still remember the words. We can associate them with special meaning, and there's a special place in our heart during that time in our development. As social scientists with expertise in human development and health, we know that there is an important theoretical foundation for connecting music with nutrition, especially with adolescents. Research intending to address dietary quality recognizes the importance of attitudes, including in particular a type of attitude called an affective attitude that relates to the way that a person feels about or has an emotional connection to an object. And in this case, we're using this theory to apply to foods and specific foods, healthy foods. Affective attitudes are a key driver also of dietary intentions. And an important moderator of this relationship is self-concept. And music, we know, is closely tied to how youth express their self-concept and also define it themselves. It's also very likely that an adolescent's attitude toward food is probably a stronger driver of behavior than it is for adults, given their stage of cognitive development, because we know adolescents live in the here and now. While music-based interventions have been used to address numerous public health issues such as mental wellness, homelessness, HIV prevention, there's actually not any observed music-based nutrition education interventions in the peer-reviewed literature at this time. We really believe that this work, while it's still in a pilot stage, is critical as a mechanism to demonstrate the potential of using art, and in this case, music, as a conduit to shifting health behavior in adolescents, especially those from underserved communities. Our mixed methods research will focus on attitudes and self-efficacy as a mechanism of exploring this relationship between the factors in self-concept. And we've also included more traditional outcomes like dietary intake. Matt, do you want to talk a little bit about Conscious Connections?
Absolutely, thank you. Conscious Connections is a local nonprofit located in Northeast Wilmington. We use arts and agriculture as our platform to reach underserved populations. Currently, we have about 11 parcels, which totals about 1 acre worth of land, where we converted into an urban farm. There, we grow select specialty crops. We run summer youth programming as well as after school program. We also operate a modified CSA. We have a project where that's titled Feed the Community Feed, where we feed people in the neighborhood that are dealing with food insecurity, as well as we host local community events. Promoting nutrition through music is important to us because we believe that youth understand their own power to become creators in their community. They transform their own lives in their communities. And music is a form of nourishment that is a conduit to transform youth from being a consumer to a creator. We're going to teach youth to approach their lives holistically through teaching them to be creators of both music and nutrition to improve their overall quality of life. We'll be working with Calvin Quince, who is a retired music composer that performs local ministry in the community. He works closely with the youth, and he's extremely talented and skilled in his craft.
So thanks, Matt. So to talk a little bit about how we plan to achieve our research aims, we will design and test a 4 to 6 session music-centered nutrition curriculum for middle and high school youth. And it will be taught in an after-school setting, in a community setting. The curriculum's aim, similar to what Matt was saying, is going to include the music piece, so teaching foundations of music, but also teach the importance of a strong mind and body, the ways in which food feeds us, and how better food choices can be made locally. So it's focused on our eating behaviors and also how to interact with your current food environment. The curriculum will build off of several existing efforts, including SNAP Ed materials. And our effort will seek to elevate the work of successful musicians and role models who have been vocal about the importance of health and nutrition in their lives. So some examples of that are American rapper A$AP Rocky and singer Lizzo, who have lyrics that speak to their attempts to adjust their lifestyle in terms of eating and the benefits they see from that. So students will not just learn about the benefits of a healthy diet, but also explore their own attitudes towards food, as well as how they and others, including these artists, ascribe meaning to healthy food. So we'll have 20 youth that will participate in the sessions. And at the conclusion, the youth will work throughout the process. They'll be working with Minister Quince, and they will work to record their own song. And the song will be developed with that music expertise to make sure that it's current and appealing to young people. So it's something they'd actually want to listen to and be proud of. And then also informed by the nutrition health researchers on the team to guide some messaging development around healthy eating. The group will also select a best song, which will be a product that could be shared with other community-based organizations seeking to improve nutritional health of young people. And the strategies that we established during these sessions will be documented in a guide, which will enable replication as well. So Allison spoke a little bit to our evaluation. Just to dig into some specifics, we plan to complete pre and post intervention measures, nutrition knowledge and attitudes and beliefs about fruits and vegetables and sweet and salty snacks will be assessed using validated NCI surveys. We will assess self-efficacy towards purchasing and consuming better foods for you. And in order to measure diet, we'll perform a short dietary assessment and also utilize a novel tool, which is owned by University of Delaware, called the Veggie Meter. It's the only non-invasive biometric measure of fruit and vegetable intake available, and it's been tested with participants at Conscious Connections previously. And last, we'll have some brief qualitative interviews with participants to examine if and how the program influences their self-concept. So now we'll speak to our own expertise in as far as our team membership. Allison, do you want to go first?
Sure. So we have some really great expertise at the table. I'm Allison Carpin. I'm really great. I'm going to support the research and process evaluation components of the work in concert with Dr. Katie DeSantis. And this is an exciting collaboration for us because while we've known each other through sort of networks, we've never had the opportunity to work together, and it's kind of fun to collaborate with Jefferson at this point. I've published over 100 articles on food access and health that are focused on community-based efforts in this space, and this is very much aligned with my area of expertise. I also have several books on this topic generally, and also I've been practicing in the field for about 15 years. I come from a nonprofit background where I did a lot of community-based work in Philadelphia. And so Matthew and I have had a collaboration now for about 8 years going on a number of different projects. So we're very close collaborators as well. Matt, do you want to talk about your credentials?
Yeah, so I have a degree in business with a master's degree in special education. I was a special ed teacher in Philadelphia, Delaware, New Jersey for about 20 years. I am a LEAD Class 5 alumni, Delaware LEAD, which is for future agriculture leaders in the state of Delaware, the first African-American to graduate that class. I'm currently, I will be graduating from Pennsylvania Rural, which is a rural urban leadership program for future urban and rural leaders. Graduation is next week. I worked as a population health specialist, doing a lot of community-based work. I spent a lot of time in the community working with different organizations throughout the city of Wilmington.
All right, Katie, I'm looking at our time, Matt. I'm going to cut you off. Katie?
I'll go briefly. So I have extensive experience in managing community-based research, utilizing mixed methods approaches, and I've also published quite a bit on food access and health equity. And my postdoctoral training with the Council on Black Health is really what got me on the path of studying and working on health equity, and I still work with the council as a consultant on their projects. And this project is really the ideal next step because we recently published an article in the journal of Racial and
time.
Okay.
Thank you.
Thank you.
Thank you all. You squeezed in as much as you could, and we appreciate that. Thank you so much. And thank you for sharing with us your innovative work on promoting nutrition through music and innovative ways. Matt, congratulations on your forthcoming graduation. And I would like to open it up to our sharks now for their questions.
So this is Dave Whalen. I take the first question here. I want to congratulate the team on putting together a great intervention for, certainly very compelling in terms of the need. One question I had, which I just didn't hear, is has this type of intervention been used to change lifestyle behaviors like nutrition or exercise or anything of that nature? And in this age group in particular?
So where the literature lies right now is a bit in the theoretical space around the relationship between self-concept and affective attitudes. And music is also clearly tied to those things. There has been work done in behavioral change around risky behaviors related to HIV prevention. And also some other preventive behaviors more generally in health. But no, the answer is no. Surprisingly, there has not been this application and connection between these two issues yet, despite what I think is good scientific rationale to do so.
Excellent. Thank you
I
for
think
that
people are trying to
question.
talk.
Oh, sorry.
Mindy, you first.
Go ahead,
I'll go after you. You had your hand up.
Oh, okay. Sorry. So I guess the answer that you provided to that last question speaks to its how innovative this study really is. Congratulations. I think that the team is a terrific collaboration. My question is about how you plan to have parental or guardian buy-in. Obviously, you need it, you know, because these are minors, and so you will have to have their permission for them to participate in the study. But also because I think it will be critical for parental involvement in order to reinforce the students' knowledge and also to sustain their commitment to changing their nutrition patterns.
Well, we'll be an extension of our LIT crew, Leaders in Training. We currently provide summer program that since the COVID has been extended. So we offer around a year programming where we have retained some students. And we also just recently have been doing some work in Seaford, Delaware. So we plan to expand and to reach some families down in Sussex County as well. So through our LIT crew, children have to sign up, parents have to fill out an application. So we will get their permission for participation.
LIT stands for Leaders in Training, but it's also a cool word, so kids don't mind identifying being part of the LIT crew.
Excellent. Thank
Dr.
you. I've been super impressed with the work of Conscious Connections. Early in the presentation, it was noted that access is one of the major barriers for the inequities and consumption of healthy food. And I didn't hear how this project would address that, and if there was any baseline data regarding if attitudes were one of the major barriers for inequities in health. I also wanted to know if youth would inform the development of the curriculum. I know I look young, but youth, you know, can be very funny, especially high school students in regards to what's cool. And I didn't know if you would have an opportunity to incorporate their feedback in the development of the curriculum.
Yeah, Matt, I don't know if you want to take that or how you want to tag team it.
Well, yeah, youth will definitely be engaged and involved in curriculum development. Everything we do, we try to make sure that we give everybody a voice. In order for it to be most successful, that's one of the things that we try to make sure we focus on, giving everybody a chance to give their input so I can get their buy-in. A coach, so I like to meet my team or meet people where they are and build them up. So that's definitely a part of how we run things. Yes.
And we would kind of do it together. I mean, I see this part largely in Matt's hands, but I know there's some issues around like just dietary guidance and questions that might come up when it comes to nutrition side of things, where we would sort of be on standby or have some examples of, you know, healthy breakfasts or fruits and vegetable ideas and those kinds of themes that are aligned with sort of best practice. But at the end of the day, I think it's between really the musician and Matt to work with the youth to develop that curriculum.
And I think just to speak to the environment and addressing that part of your question, that the idea, you know, the better for you choices is that even within environments that aren't offering as many healthy options. There's usually, you know, healthier options that you can go with, and having that knowledge with you really helps. And so I've definitely seen that in my research, even looking at supermarkets, that when we look at what families buy at supermarkets, individuals who read nutrition labels really do a better job getting a healthier cart. And it seems very simple in terms of that act, but sometimes we really need to have that motivation to read the label and to know what we're looking for. So it's really challenging for all Americans to eat healthy, and it is about trying to empower these youth to be able to navigate any environment that they're in.
Fruits and vegetables are always accessible at our farm. Seasonality definitely does play a factor, but with the collaborations that I have, I get a lot of produce from downstate, from Sussex, and when we store it up north, we give our produce to people in the community, so the youth always have access to fresh produce on the yard.
Dr. Stanhope, you had your hand up, and Dr. Willen, if you'd like to follow Dr. Stanhope, it looks like you may have a follow-up question or additional question as well. And I'd like to just encourage our virtual audience to submit questions in the Q&A function, and time permitting, we'll incorporate your questions into this discussion as well. Thank you.
Okay, thanks, Pam. Really excited by this proposal. I'm going to cut right to the chase in terms of what I want to get to the point of kind of concept of scalability, because I heard you kind of mention that in your presentation, and it sounded about, you know, replication and those kinds of things. And I personally think replication is going to be difficult somewhere else in the world because of the special components and special opportunities you have. So I really want to get at the point of scalability through CCI and what your plans might be in terms of really being able to impact the community. So my first question goes to Matt, and that is, how many families and children interact with CCI annually?
Great question. Annually, families, we service at least 150 families annually, and that number is growing. Youth, it ebbs and flows, but throughout the year, we service about 80 youth, give or take. But now with our Sussex County collaboration, that number will grow greatly. We just fed 40 families last week in Sussex County. So we're really looking to expand on our efforts down here to just add to our numbers of people that's being serviced.
Okay, so what results would you hope from, say, your initial work with funding from the Delaware Health Sciences Alliance that would clearly knock this out of the park, so that you could get, you could really leverage extra funding with the type of information you're going to be getting and such, and really expand the number of families and youth through CCI and really make an impact in not only the Wilmington area, but other areas. So what results that you're planning on collecting would really knock this out of the park to really help you strengthen this team so that you can make a significant impact in this community?
Well, one would be the...
If I could just answer this. So I've been in this kind of position before, and especially when you do community-based research, folks are always skeptical that it's A, going to have an impact, or B, going to be sustainable. You haven't brought that one up yet, but that's coming. And the third is that it's able to be expanded nationally. I've worked on several projects where we very successfully have been able to expand it. The Apple Crunch, simple idea, kids taste different apples. It went national through the SNAP-Ed program. Once it becomes an established curriculum, SNAP-Ed, I don't even know how many millions of kids they serve each year, but it's a lot. And it's in every single school everywhere. And the problem right now is that we don't have new innovation coming into the stream for activities and educational opportunities for kids, especially in nutrition obesity prevention. A lot of the dollars and activity in this space dried up after the Obama administration left. And Delaware in particular is really starved for on-the-ground programming that's research-based, where we understand what's really happening, from the food bank to the Nutrition Food Network that I run, all the way through SNAP-Ed at a national level. There's a lot of opportunity to expand on this work. So what's the bottom line? We need some articles in place that explain what procedurally can be done. We need a toolkit out there to be able to describe how it gets done. And then we need to use these networks that I think many of us are already tapped into to go ahead and pump out that information. I think if we were able to demonstrate a relationship between self-efficacy, self-concept, and these feelings about food as a foundation, it would leverage additional dollars for this research that could make it expanded as well. And second of all, I think if we could get some good concrete qualitative and quantitative measures around short-term, we're not going to have large-term, but short-term change in carotenoid, which is a very sensitive measure, we would have enough interest that I think people would be interested in trying something new. Plus, it's fun. I mean, kids like music. It brings them into the YMCAs. It makes them want to think about something that otherwise is kind of boring. Nutrition isn't all that exciting sometimes.
Matt, were you gonna contribute to that? Thank you.
I think Allison did a great job. Thank you.
Just a real quick question about study design. You mentioned that it's 4 to 6 sessions. How do you handle if a child isn't able to attend a session? So missed visits. Is that, are these one-on-one sessions, or is it a group session and they have to make it up somewhere along the way?
My experience is that these things have to be pretty flexible. And while we say sessions, we don't mean like structured times where if you make it or break it. And in the work that Matt does in general, you have folks on site a few times a week. They can work with kids, but we would expect on average kids to be able to come in and work with the musician 4 to 6 times. We'll probably have some structured times, but then also sort of drop-in sessions so that as life happens and they can't make it, they'll get to 4 to 6, or we'll find them and make sure that we reach out to them and get them their additional sessions on a more tailored way. I mean, I don't know, Matt, that's how we've done other lit crew and art related projects that way, but.
Dr. Fernandez, I'm going to offer you our last question for this round.
Thank you so much. I was curious about the knowledge base of the kids that would develop the music curriculum. What are your plans so that you could really inform their music and have it have an impact? I mean, I know they're going to craft these and work with the musician, but I think they need to have some knowledge base.
And you're speaking to.
Are you asking like go ahead, Katie.
Yeah, pre-development of their curriculum. If you want them to have input in developing the music and having it convey the appropriate message, what's going to be their knowledge base? How are they going to be educated on healthy food choices, access, that type of thing? That was my question.
Do you want to answer, Katie?
Sure. Yeah, I was just clarifying whether you were asking whether they needed a music, prerequisite. So the sessions will incorporate those aspects of nutrition. We're going to pull from SNAP Ed and another program in Chicago to give them a focused education on fruits and vegetable consumption and the benefit of that, and the benefit of limiting sugar sweetened beverages, salty and sweet snacks. If you're able to focus on those areas, those have the biggest impact on obesity risk and also overall health. So getting that education in using curriculums that have worked in the past. And then also integrating the idea of really making the mind-body connection with food and understanding, how to navigate their own environment. So making sure they know about the free access to produce and understanding what choices you have within the stores that you have access to in walking distance.
Thank you.
Trying to avoid the didactic. So I think it's really just a matter of core messages and having discussions with kids about it and letting the musician weigh in on how he wants to talk about it, and us being sort of on standby to guide if any of the messaging seems off best practice. But I don't really want to infuse a bunch of hardcore curriculum because that's just going to tune kids out. Yeah.
I agree.
And one thing, and one thing,
but I wanted to know a little bit more specifics. Yeah, I'm sorry, Matt.
no, and the lit crew is made up of vegetable characters. Also, I didn't mention that. They're vegetable characters, all veggies that we grew in our yard. And some of, we have tomato Tubman, and it was another way that we folded in Black history. So we have tomato Tubman, Barack Lee, Huey Mellon, Malcolm P. And now we're getting into dedicating characters to local people such as Pastor Lottie Lee Davis. So we have a pepper called Lottie Lee. So, we use the vegetable characters as a way to I like to just remind them, the more green you eat, the better, especially for those kids that, are really particular about playing sports. You are what you eat. So that's a way that we convey that message.
Thank you. That's very helpful.
Thank you all. Thank you, Group 2. We're now going to go ahead and move on to our SHARC scoring. And so SHARCs, if you'd like to go ahead and access the rubric link for Group 2. Group 2, similar to Group 1, if you could please remain available during the scoring should there be any follow-up questions or need for clarification during scoring. We will reconvene at 2:55. Thank you all. Welcome back. I'd like to welcome our third and final team presenting today, representing a collaboration between Thomas Jefferson University and Nemours Children's Health, focused on addressing substance use stigma and bias in the inpatient setting, a novel interactive training for healthcare providers. Dr. Smith is elevating the team and will let our final team know when their time begins. Best wishes.
All right, there's quite a few of this team. Hang on, give me a second.
While that team jumps on here, here's a question for the SHARCs. Did anyone recognize the piece of music being played? Someone's got to recognize one of the most famous jazz albums of all time.
Is that from Kind of Blue? Miles Davis.
Oh my gosh, Dr. George Weinstein yes, Dr. George Weinstein has won the non-existent prize. That was indeed Kind of Blue by Miles Davis. And my son, when he was 2 years old, the first piece of music he liked was in fact that piece, which was Freddie Freeloader from Miles Davis's Kind of Blue album. And he's now about 21 years old. So it was a few years ago.
All right, I think I have team 3. Have a look around team 3 and make sure everybody has been elevated. All right, and if you're ready, your time starts right now.
Hello, everyone. I'd just like to introduce our team with us here today, and then we'll get started. So we have with us Dr. Tara Flood, who's a clinical nurse and assistant professor at Jefferson College of Nursing. We have Dr. Neera Goyal, who's a pediatrician and researcher at Nemours. We have Dr. Vanessa Short, who's assistant professor in OBGYN. Dr. Steve DiDonato, who's an associate professor in nursing. We have with us also our study team. I see Dr. Diana Bartomarco with us today from Jefferson with the Monterre program. And myself, Dr. Gannon, I'm assistant professor in OBGYN at Jefferson. And I will hand it off to Vanessa.
Thank you, Dr. Gannon. So as we are all likely aware, the opioid epidemic continues to have a substantial public health, societal, and economic impact in the United States. Between April 2020 and April 2021, Americans died of drug overdoses in record numbers, and more died from overdoses than car crashes and gun fatalities combined. The US opioid crisis has had a significant effect on people from all walks of life and stages of life, including pregnant women and infants. The number of pregnant women with an opioid use disorder diagnosis at delivery has quadrupled since the 1990s, and the incidence of neonatal opioid withdrawal syndrome increased nearly 7-fold during this time. Although the epidemic is a national problem, geographic disparities do exist, and some states are worse off than others. For example, Pennsylvania and Delaware, 2 states represented by members of our research team, are in the top 10 states with the highest drug overdose death rates neonatal opioid withdrawal syndrome rates, and maternal opioid use rates. For the mother-infant dyad, opioid misuse and exposure may be associated with adverse outcomes. Therefore, providing compassionate and effective care and support for pregnant women with opioid use disorder is critical for optimizing maternal and infant health, eliminating disparities, and addressing the worsening opioid crisis. Dr. Goyal.
So women with substance use disorders and opioid use disorder more specifically experience more sociodemographic and healthcare disadvantages, pre-existing health conditions, and comorbid psychiatric diagnoses than their counterparts. There are higher rates of postpartum depression in this population, preterm birth, fetal death, neonatal mortality, and low birth weight among women who deliver with a substance use disorder. They're also more likely to experience emergency department visits and hospitalizations during the antenatal period, and they're less likely to utilize prenatal health care. Compounding these disparities is healthcare provider bias, which perpetuates disparities in trust and is attributed to providers' lack of education, resources, and training in the complexities of substance use. Our research team has conducted multiple previous studies that look at the perceptions of pediatric and perinatal care and related gaps in care. For example, we recently conducted a cohort analysis of over 11,000 children in our primary care network at Nemours that demonstrated that children with intrauterine opioid exposure were 50% less likely than the general population to receive adequate well child care, and on average had two fewer well child care visits in that time frame. And less than 2/3 of participants that we in previous survey interviews that we've conducted report that their healthcare providers knew information about their child's medical history, listened carefully, and explained things in a way that was easy to understand. So this really suggests opportunities to increase the family-centeredness of care and the relevance and value to address healthcare disparities in this population.
So gendered perceptions of women who use substances are pervasive in mainstream society. Women experience a greater stigmatization than men who use substances, as this behavior is contrary to the public belief about expected behavior in pregnant and parenting women. Women also express the challenges of overcoming stigma, as they often are ostracized, excluded, or shamed. More specifically, pregnant and parenting women with opioid use disorder may be seen as bad mothers in the eyes of society, as they violate the socially defined roles of the nurturing caregiver. Healthcare providers often report personal stereotypes and prejudices they assign to perinatal women with opioid use disorder. These negative attitudes can impact how healthcare providers engage in patient care. It may cause them to be less engaged and have less empathy for the mothers. Witnessing these personal encounters continues to impact the nurse's ability to deal with their own stress when subjected to physical and psychological demands in practice, as many nurses are subject to ethical dilemmas and moral distress while providing care to this mother-infant dyad. In 2018, the American Association of College of Nursing identified a future goal to include an enhanced curriculum to address the opioid epidemic. Providing opioid use disorder education can be a useful tool in undergraduate curriculums in nursing, and can also be useful to build confidence, competence, and reduce stigmatizing attitudes. These efforts may improve patient care delivery and recovery efforts in this vulnerable population.
To address these disparities in care around maternal opioid use and the gaps in knowledge and education that nurses experience in caring for this population, we propose a two-phase mixed methods research study to develop and implement a substance use disorder training and education program for hospital nursing and study its effectiveness on nursing attitude, knowledge, beliefs, compassion fatigue, and burnout. The study will specifically focus on hospital nursing, those who interface with maternal patients with substance use disorder, including those nurses working on the acute stabilization floor, labor and delivery, and the neonatal intensive care unit. Our proposed study draws on our collaborative work together as a multidisciplinary research team consisting of faculty from Nemours Department of Pediatrics, Jefferson's College of Nursing, and Jefferson's Maternal Addiction Treatment Education and Research Program, or MATER, which resides in the Department of OBGYN at Jefferson. Nemours brings expertise as a leading children's hospital serving the Delaware population. Jefferson's College of Nursing brings its innovation in nursing clinical care as well as nursing education, as well as Mater, which is a national and international leader in substance use treatment and research with an extensive research portfolio. Our team consists of practicing clinicians and academic researchers and have significant experience translating research into practice through implementation-based science methodology. This work also builds upon one of our current research studies, examining the patient and nurse perspective of the acute stabilization period. The acute stabilization period is when a patient presents to the ER and her withdrawal symptoms are managed inpatient, where she begins her methadone maintenance treatment. Our current work is eliciting the perspective of nurses caring for maternal patients in this acute stabilization period, as well as the maternal patients undergoing this care. Some of our initial data reveal that nursing feels that they do not have the tools to support this population, including not knowing what recovery looks like or what treatment services patients will transition to once they leave inpatient care. Likewise, maternal data reveal that gaps in care and perceived stigma not only occur in the acute stabilization and L&D floors, but in the NICU, making way for our collaboration with pediatrics and MORS to address these disparities together. These data, as well as the systematic review that we are wrapping up related to nursing and substance use disorders in the acute stabilization period, will inform the development of the proposed substance use training nursing intervention. The substance use training will include education around maternal opioid use and context, prevalence of maternal substance use, presentation of withdrawal, neonatal abstinence syndrome, stigma, implicit bias, and importantly, the language of recovery. We will also include a self-compassion mindfulness component for self-care to address nurse burnout and compassion fatigue, utilizing mindfulness experts, including Diana Batamarco, as well as several others. We will use a hybrid design offering both online content as well as in-person sessions, offering opportunities for nursing to interact with Mater clinical staff, to hear about recovery and what outpatient and residential treatment services look like. I'll now turn it over to Dr. DiDonato to talk about phase 2 of our proposed work.
Thank you. So in phase 2, we anticipate recruiting about 50 nurses using convenient sampling from Thomas Jefferson University Hospital acute stabilization floors, labor delivery, and NICU. We intend to use 3 cohorts, about 15 to 17 nurses, to pilot the education and training. The current study that Dr. Gannon talked about is also helping us to inform that optimal delivery of the in-person segment, whether that is, for example, small groups during shift versus off-shift training, in addition to that online education. And we'll use a pre-post design looking at outcomes such as the professional quality of life scale, the medical condition regard scale, the 5 facets mindfulness scale, and an investigator-initiated survey on the attitudes, knowledge, and beliefs on trauma and substance use.
5 minutes.
We hypothesize that by the end of the training, the nurses will see improvements in knowledge around substance use disorder, as well as an increase in their perceived mindfulness and an increase in their attitudes towards patients with substance use disorders. We also anticipate that they will see an increase in their compassion satisfaction while seeing a decrease in compassion fatigue and burnouts. We will also, using the mixed methods, engage in focus groups who collect tacit data on the experience of the training to inform adaptations and improvements to the curriculum, as well as how the training has impacted their own care, the nurses' care of maternal patients with opioid use disorder. Additionally, we anticipate that focus groups will help the research team further understand how the nurses' personal emotional experiences in caring for this population and how the training and education can support overall nurse well-being and team culture. We'll use an investigator-developed focus guide, and our team has extensive experience in engaging in thematic analysis already within qualitative methodology. From a sustainability aspect, we plan to lead with nurse residency programs. All new nurses go through this over an 18-month period. We also have support from leadership within Mater, Jefferson, as well as the MORS to begin to implement and sustain this work. We have Jefferson's nursing education office, which will help support providing continuing nursing education credits at no cost for the training. And this project continues on a collaboration partnership among Jefferson and Nemours, and it's synergetic within both institutions' missions. Specifically, Nemours, as an example, Nemours Primary Care Task Force that is focused on establishing a standardized care pathway for mother and baby dyads affected by opioid use disorder. And this intervention from this project can easily slot into provider trainings for that project. This work also fits within Jefferson Health nursing strategy to continue to build a resilient workforce with a focus on health and wellness. It also fits within Jefferson's institutional commitments to reaching outside of our own institution to connect with and help underserved communities locally. We also anticipate that this will be seed funding to establish training interventions and pilot the intervention for future grant work through external funding opportunities to further test this. We know this will have a great impact on Delaware's population health. We're in the midst of a nursing crisis, both on the front of retention and also on the overall health and well-being. We will continue to lose our nurses if our professional development does not address nurse well-being along with patient outcome goals within education. This project intends to enhance not only the abilities for nurses to better care for the women during this period, but also to support a vibrant workforce. And by doing this, by supporting a vibrant workforce, by continuing to develop that, we believe this project will enhance the care received by women who have complex needs before and during and after this phase of treatment. And I'll pass it back to Dr. Gannon to close our presentation out.
All right, thanks. So in conclusion, there's a demonstrated legacy of our partnership across organizations and departments through a previous 5-year Health and Human Services research study with Jefferson and Nemours, as well as a current 5-year AHRQ-funded R18 study led by Drs. Goyle and Short, as well as several other smaller research projects we all work on together. Across our collaboration, we have 14 joint manuscripts in the area of maternal substance use and over 7 years of successful research collaboration. The opioid crisis is a public health crisis with lasting implications for the maternal child dyad. Our research study is critical to address identified disparities and improving the care that maternal patients with OUD and substance use disorder receive, as well as supporting our hospital nursing staff. Ultimately, the study will aim to impact the care provided to the maternal child dyad affected by substance use disorder, which in the long term may have implications around recovery. We thank you all for your time and invite any questions that you may have.
Ooh, seconds left. Well done.
Wonderful. Thank you so much. Sharks, the floor is yours for questions.
This is Vicki. That was just terrific. There was so much in there that, I was hanging on to every word, every sentence. I hear what you're saying about nursing healthcare provider burnout, and I'm sure that's worsened during, the COVID pandemic. What opportunities are there also to enhance the awareness of non-healthcare providers within our healthcare systems, as well as even physicians regarding burnout and the knowledge gap that nursing sometimes experiences in dealing with this crisis, the opioid crisis?
So is your question directed at how this can be translated or how we can help educate others on nurse burnouts?
Yes, downstream, and how that can actually indirectly impact nursing retention, if you will, because it's an understanding not just from the patient family perspective, but it's also an understanding from the physician and other non-healthcare providers that are part of our systems.
Thank you. Dr. Flood, were you going to jump in?
Yeah, so just to integrate that, I had we looked at some of the self-care and wellness, and some of my doctoral projects was specifically with NAS patients, nurses who take care of them. So those efforts that we're speaking about with this project can also be transferred onto other healthcare professionals, including physicians, because they've, of course, also have incorporated in this stress from, excessive work for COVID and so forth. So it can be transpired onto any of the healthcare populations. Some of the tools that Steve had mentioned are for multi-healthcare providers. So it just wouldn't be nursing space. And maybe an extension of this project could be looking at other healthcare providers, just not the nurses' education per se.
One thing I will add to that, thank you, Tara, is that in our previous study that was led by Dr. Abatamarco, the Health and Human Services funded study, that was a joint project between Jefferson and Nemours. And part of that project was a practicing safety quality improvement initiative in the pediatric practice at Nemours, where a lot of the patients from Mater go to for the pediatric care of their kids. And part of that was not only this QI work, but training of those pediatricians as well as their staff, so front office staff, MAs, nurses, the whole office, on substance use training. There were several faculty from Mater that came and gave talks to the staff about substance use. And then we had mindfulness experts that led mindfulness training with the staff to address some of those concerns of compassion fatigue and burnout. So we have some previous experience in developing some of that intervention work and then applying it in a different setting. And I agree to your point. I mean, we're targeting nursing in this intervention, but really it goes beyond that in terms of burnout and who's interacting with this patient population. And one thing I might add too, I'm so sorry, is that
this is great.
I think that in our intervention and what we're hearing in our current study from mothers who are experiencing this care is it's not only the barriers and the challenges of nursing, but we're hearing too is some of the supports and the things that nurses are doing, healthcare providers are doing that are really assisting our moms. And some of the moms saying, this is what helped me get into my recovery and to stay that week because I wanted to leave the hospital, and this person made me stay. And so then it's asking them more in this interview, like how, what did they do? And so I think that in our intervention that we're creating with nursing is addressing some of those supports that we hear from moms and letting nursing know, these are some of the things that we're hearing that you guys are doing really well and is really supporting mom, not just this is not, these are the things that you need to improve on.
Excellent. Thank you.
Dr. Rather, you have a question? Oh, you're still muted, Dr. Rather.
I'm consistent. Huh? So this is a great proposal. I'd like to thank the investigators. My question is, given the workforce shortage we're experiencing nowadays, I believe that the cohort of nurses who are going to champion this cause have to be, they have to be truly engaged in an authentic manner with this project. So how are you going to enroll these nurses and gauge the level of engagement when it comes to your project?
I think that if I could start for the team, we've seen throughout the interviews with the nurses, and we've interviewed nurses on antepartum, labor, delivery, and postpartum, that there is great passion for working with this population. There might be even greater passion around the fact that we learned very little in their formal nursing education about the emotional toll on ourselves about this, as well as how to treat the psychosocial emotional end with these patients, and the kind of post-discharge, what happens next, where do we support? And we have been amazed at how many nurses came out of the wood immediately as soon as we recruited for the other study. And I think across the 3 floors and all the floors who work with these individuals, we've seen there's motivation behind this to continue this work, to engage in this training, there's also a lot of motivation from leadership. There's motivation in nursing from our dean in the College of Nursing, from the leadership across the health system, and as well as nurse management to ensure that we enhance and we support the wellness, the well-being of nurses, not only the patient outcomes, right? That's always been a motivation, but there's a really large push right now so that we are supporting the way in which our nurses feel supported so that they're sustained and that they're able to continue working with this population and stay in their role, right? That we're not seeing the turnover. So I think at all levels, the motivation is there for the engagement in in the training, and as well as sustainability and forwarding it. And there's also a push across, there are nurse externship programs across Jefferson, and that is a initiative and a drive right now and an aim to increase the number of nurse externship slots and programs that this could be embedded into.
Very impactful, potentially the impact of this project. My question is, I know that there have been varying degree of results in regards to training impacting biases. And so in addition to evaluating the nurses, how they feel about the training, will there be the opportunity to collect any longer term outcomes and changes in behavior, and also identify additional barriers in addition to knowledge that may be impacting the nurse's ability to provide the best care?
That's a great question. In terms of looking at the long-term effects, that is definitely one thing that we're interested in looking at, is that how long does this training, how long does the effect of the training endure? Given the short time period of this study, we thought that having 3 different cohorts going through with the pre-post design would be the most effective for this one. However, that is something that's really interesting that we could consider, is adding another time point into it, and something that we've thought about in future studies when we pilot this at multi-sites. So the idea is that this proposed study would pilot this intervention, and that it would seed data for further grant proposals, maybe to like NINR or something, for a multi-site study where we would really look at the sustainability of it. And one of the other longer term implications that we're interested in is the impact on maternal recovery. So retention and treatment, and things like that, some of those domains. That's a great point that you brought up.
Dr. Stanhope?
Thank you. This sounds like a very impactful program, and I really like the designs and the various concepts. But I can't help but notice it seems to be very Jefferson-centric with regards to phase 1 and phase 2. And that's okay, but I'm looking at the review criteria that we're asked to utilize here, and I'd like you to go right after and address 2 concepts. One is, what's the likely impact on Delaware's population health of this particular activity? And the second one is with regards to sustainability of the research, and what would be your plans to pivot the research to impact Delaware's population and to sustain it with the engagement through Delaware?
So I can speak to this a little bit just as a pediatrician in the Nemours Children's Health System. I mean, we are the newborn and neonatal providers for Jefferson Hospital, and I think I very much view this as something where lessons learned and interventions that are sort of gained from this pilot study could be really disseminated into our other hospitals that are delivering care to mother-infant dyads in Delaware, including the NICU at Nemours in Delaware, but also Christiana Health Systems, working with our neonatology division, colleagues that are sort of really cross-pollinating all of these institutions. So I do think this is something that could be very portable and leverage relationships that Nemours has with multiple delivery hospitals.
Dr. Goyal, as a quick follow-up, are these different organizations and institutions aware that this project is potentially coming down the pike, and have they provided letters of support?
I know, I'm not sure, I don't know if Megan, if you want to relate to that. I know we have Department of Pediatrics support for this. So yes, would be the answer, but you know, at a departmental level, and I think if funded, certainly that would be, you know, one of the steps of this project and successful execution would be engagement with the neonatologists, you know, more specifically, who are certainly working with this, working with these nurses hand in hand. They're important stakeholders. But I think, you know, to one of the other points around, you know, does this translate to other provider types? You know, I mentioned some of the work that we've been doing with primary care pediatricians. I think neonatologists is another stakeholder group. Nurses are really critical because they have so much one-on-one time with the patients. They're so impactful to the patient experience during the hospitalization. But I think this is a priority for all of the providers that are engaged with these babies.
Dr. Wellham?
Yeah, thanks, and great project, very compelling, interesting. Certainly this issue of opioid, the epidemic that's occurring in the country makes this a compelling project. But one question I had was just at the end of the day, when you have a cohort of 50 nurses, you know, each of those nurses are going to come from a different background and have a different characteristic. And I guess my question is, in your experience in doing these types of studies, how have you controlled for that variety when looking at results and attitudes and education and learning?
So I can start with this, and perhaps Dr. Short might have something to add. We, in the investigator-initiated survey that we will be administering to gather some demographic data as well as other data on the nurses, we will include elements of what their education and training and background is. So usually in previous studies, we control for those variables in that way. Dr. Short, is there anything that you would like to add to that?
I think that's accurate, Dr. Gannon, but also in the qualitative aspect, I think the sample size that we're proposing, I think, is certainly large enough that we will reach saturation, meaning that we can kind of make a strong point for the findings that we report out, meaning that enough of the participants kind of agreed with one another and that the themes were seen with a large number of the participants. So I think the proposed sample size, like I said, is certainly large enough that we will reach saturation within that sample size.
Thank you so much for presenting today on this compelling work and impactful work. I do have two questions in the chat that I'd like to go ahead and ask the team at this time. I'm going to ask it as a two-part. One is, will nursing students be offered the training? And then to clarify, would the buy-in for participating nurses be obtaining CEUs and/or completion for graduation from nurse residency programs?
So I can speak a little bit about that. And Steve, if you want to add to when I'm done. Yeah, currently there is just a small amount of education, and I'm speaking from the Jefferson College of Nursing, in regards to education for students in undergraduate programs, of course. They basically touch on NAS, which is the neonatal abstinence syndrome, in their pediatric lectures. But other than that, there's really not any incorporated opioid addiction, a little bit about women with substance abuse, but nothing really in detail. So coming up with some type of formal education is essential to reduce some of these biases and also reduce that stigma that we talked about because many of these students, a lot of students, especially female students, like to go into the realm of mother-baby or pediatrics. So looking at that population, the education is definitely warranted in this situation. The second part of your question, if you can just say that again, I'm sorry, Pam.
Oh, hang on one second. The question is to clarify, would the buy-in for participating nurses be obtaining CEUs and/or completion for graduation from nurse residency programs?
So during the nurse residency program, specifically at Jefferson, and again, this would not just be incorporated at Jefferson, that would be one of our pilot things that we're doing now, and hopefully other schools within Delaware can use this also when we come up with that. So CEUs, yes, definitely would be an opportunity, and some of that information that we're considering from our qualitative studies from these nurses will probably help engage those things we want to start educating about the population.
Thank you so much. Thank you again for your time here today and for presenting again this compelling work. At this time, we're going to invite our sharks to proceed to the scoring for group 3. And we do ask group 3 if you could hang on just in case there are any final questions or points for clarification during the scoring process. Sharks, Dr. Smith will have an announcement in our Shark chat momentarily. We will hop off into another quick meeting, Zoom, for a quick discussion and deliberation prior to the announcement of the awardee. So thank you so much, and we'll reconvene in about 15 minutes or so. So our audience has a clear delineation that they are in support of group 3 as the awardees, although well done for all of our research teams, and certainly value in all of the projects.
Indeed.
This is what happened last year, I remember.
It is. Yes, the audience had an opinion, and and the scores reflected the scores. So, Dr. Khan, would you like to say a few words? Oh, you're muted, Dr. Khan.
Sure. First of all, thank you. I'm sorry. I thought you were calling out Dr. Rather. So in reference to him, I made sure I muted myself, just like he does. Thank you very much to our judges. Thank you to the panelists and to, of course, the participants for putting yourself through the research Shark Tank. As I mentioned at the outset, I actually think this is the way research should be done, studied, funded, and discussed in the public eye with clear discussions, clear guidelines, directions, and having community input. This is just one way that we like to do it, and we think we get some pretty good results, as you saw from our folks from last year. So we have a winner, and Pam will announce the winner. And drum roll, please.
Yes, so as Dr. Khan mentioned, we do have a winner. I again want to thank all of our teams for submitting and for presenting today for our finalists. The scores were close. However, we do have, actually, I want to ask Dr. Smith if she can elevate the lead point of contact from the teams, and then we'll make our announcement. So we have a representative present. Lesson learned from our competition last year. We want to make sure we have team representation here.
It's also Pam's ploy to build suspense. So
drum roll. All right, very good. So again, thank you to all. The scores were very close, but we do have a winner based on the scores, and I would like to at this time congratulate the collaboration between Thomas Jefferson University and Nemours Children's Health with the research project, Sensory Adaptive Experience to Improve Access to Healthcare for Children with Autism at the Swank Autism Center. Group 1, congratulations on being our 2021 research competition awardee of their $50,000 grant from the Delaware Health Sciences Alliance. And I believe Dr. Smith is elevating the team as we speak, and we'd love to invite you to say a quick word, and then we'll wrap up for this afternoon.
Team 1, congratulations. That is wonderful news. And your team, of course, received the highest number of positive evaluations, and very, very well deserved. And we'd love to hear a couple of words from you if you'd like.
Well, I'll start and then I'll let the two students go. Thank you so much. We feel very fortunate. This was all of the projects seem so deserving and so timely. And so we're just thrilled that this project is being funded. And I want to thank Danielle and Rachel, who did so much work to prepare a really scholarly presentation.
Absolutely. Thank you so much, Roseanne. And I also want to mention that this happens to fit nicely with the priorities of one of our member groups here as well for this next year for the Delaware Academy of Medicine and Delaware Public Health Association. The issue of autism, as you heard from Dr. Swanson, the current president, is going to be on the forefront for the next year. There will be a journal issue dedicated to the topic. There will be a conference dedicated to the topic as well. So we'll put you in touch with Dr. Swanson and their team, and hopefully you can help amplify your efforts across the state, which is kind of the point of this award. I also want to say congratulations to our other two finalists for teams 2 and 3. One thing that the judges all agreed on, that in a sense, these were all wonderful research projects that deserve the right kind of support. And we will be in touch with you as well to suggest some other avenues for continuing support. Being a relatively small group here in Delaware and the surrounding area, we can make some links for you, whether through the Delaware CTR program, through the Partnership for Healthy Communities program, and others. And some of those suggestions did come up in the discussions, and we will be in touch with you as well. So congratulations to all of you. Congratulations to Team 1. Thank you for all you do for the care of our communities and our patients, and for, again, building these bridges and building a stronger Health Sciences Alliance. Thank you, Sharks. I'm glad that you weren't too cruel this time. Thank you, team, for all of your hard work, and thank you, Pam, for leading us through today as the Mistress of Ceremonies. Much appreciated.
Yeah. And Danielle, your reaction was priceless. I wish I had captured that. It was just delightful. You as students did such an incredible job. Amazing.
Yeah.
Thank you so much. I appreciate that.
Well, I think you did your mentors proud. Congratulations.
Yes, so proud. Thank you.
Thank you, everyone. We will see you next time.
Thanks again.
We will be in touch with all sorts of things, checks and letters and plaques and whatnot for all 3 teams of recognition. So thank you very much.
Thank you.
We'll see you soon.
Thank you, everyone. Take care.
Patience.
Bye.
Bye.